Okay, let's get started with this podcast for Chapter 2. There are 11 objectives that we will discuss during this podcast. There are 108 slides in this particular podcast, but we'll go through it rather quickly. I'm not sure that we need to go over each and every slide. A lot of them there may be like 3 slides that cover the same material, just more going deeper into the concept or idea. Bear in mind that there will be 6 questions on the IRAT for chapter number 2, and I will be giving hints as those on those as along the way. So again, like I said, there's 11 objectives. We'll be addressing each and one of those. Let's see. What is a profession? Essentially, professions exist to serve society. And until more recently, when some changes were made in pharmacy. Pharmacy wasn't really considered a profession until about the 1990s when I was just starting pharmacy school. Then it was starting to be recognized more as a profession. There are different characteristics of a profession, and you see these here. I would say that you really need to know those characteristics that are included to characterize the profession. You need to know all of these, as there will be an IRAT question, and each of the 5 bullets is further discussed in the next 5 slides, and you can read these in your textbook. But again, you need to know that all of these, the systematic theory and body of knowledge, the professional authority and special privileges, the community sanction and social utility, the ethical codes and internal control, and the professional culture and organizations. These all characterize a health professional. So again, going through these, I won't go too much into them. Professional culture and organizations. So, for example, pharmacy is now considered a profession. There are certain values, central beliefs of a professional. We believe in the importance and merit of our profession to society. We believe that our service cannot be better provided by another occupation, and we believe that the service provided is essential. Now, you may talk to nurses, and they might express that they would like to believe that they can do what we do better and less expensively. But again, we're a profession, and we think we can do it better than the nurses. There are different norms. There are accepted ways of behavior. There is in most state rules and regulations for pharmacists a so-called tattletale rule. If you see a fellow pharmacist doing something illegal, it is incumbent upon you to report it. Now, other folks that aren't professionals, they don't have that tattletale rule. We, as professionals, we tailor our counseling and our care to the patient in front of you. Everyone in front of you as a patient is different and should be cared for differently. Again, tailoring is the hallmark of a professional, how they tailor their care to a patient. Now, we're going to cover several different professions. That's the bulk of this particular podcast. So, right now, we're going to switch gears to a discussion of the different healthcare personnel, starting with pharmacists. Now, pharmacists distribute prescription drugs to individuals. For a long time, they've never administered. Nurses and physicians did that. They also advise their patients, physicians, and other healthcare practitioners on the selection, dosage, interactions, and such, and side effects of medications. They also compound. I would like to point out that in a pharmacist's scope of practice, essentially, that's what the state allows a professional to do. It says what they can do and what they can't do. For a pharmacist, their scope of practice, they are not supposed to diagnose. They screen. So if anybody asks you, can you tell me if I have diabetes or not, and you run a quick test, or if you ask a few questions, you're not diagnosing, you're screening. So at best you can tell the person, well, I think you might, but you need to go see your doctor. If you diagnose, you're breaking the law. Education and training, you can see it has increased over the last century, and it's now 6 years long with the PharmD program. There are now introductory pharmacy practice experiences and advanced pharmacy practice experiences that are required by our accreditors. You're going to have some experience with the introductory pharmacy practice experiences for 2 weeks later in the middle of the semester. Residency training. I did a residency back in 1980 at the Johns Hopkins Hospital in Baltimore. They didn't call it a PGY1 residency back then. They just simply called it a hospital residency. That's when hospital residencies in hospitals were something of a new phenomena. But there are PGY1 residencies that are very general in nature. So you spend like a month, like in adult medicine, another month in another area like drug info, another month in pediatrics, another month in oncology, and so on. Very general. Get an overview of all the kinds of care that you could provide. Whereas there are PGY2 residencies, which are much more focused in nature. So, like, for example, if you went to a PGY1 residency and you saw all these different kinds of care from month to month, you might say, oh, I want to be in oncology, or I want to be in drug info, or I want to be in administration, that kind of thing. For me, when I did a hospital pharmacy residency, I seem to like hospital administration. I want to be in the management and leadership. So instead of doing a PGY2, I don't even know that they called it back then, I went into an MBA program. There's fellowship training, which is even further training. It's directed, highly individualized. So there's some programs that you may take for a year or two beyond your PharmD, maybe in a focused area like pharmacoepidemiology, pharmacoeconomics, or pharmacoethics. Licensure. I'm licensed in 6 states, 3 of which used to be very difficult to get licensed in. It was very difficult to get reciprocity, for example, to California, Florida, New York. Now it's much easier. There's simple reciprocity requirements, but most If you reciprocate to another state, you have to take a law exam. You have to, and I should mention, you can only reciprocate off your original license. So if you, like, for example, I was originally licensed in Maryland where I did my residency at Johns Hopkins. So to reciprocate to another state, I have to show that I have that state license still in good standing, and I maintain that. Don't let your original licensure, for example, if it's in New York, lapse, or you'll have to take the NABPLEX all over again to get licensed, in addition to taking the law exam. Continuing ed, all 50 states and territories require CE. Usually it's 15 hours of continuing education credit. If your registration is 2 years long, it would be 30. And if it's 3 years long, before you have to re-register, it would be 45 CEs like it is in New York. Now, some states require certain kinds of CE for those 15, 30, or 45. So like in Florida and New York, they require an approved medication error type of CE. In Pennsylvania, where I'm also licensed, you have to do some child abuse reporting CE. So be very careful when you get registered in a state to make sure that you have the right kinds of CE and the right amount. Practice environment. Pharmacists are primarily concerned with the distribution of medications. They serve as a valuable source of medication-related information for healthcare providers. The practice environment, you do a lot of different things. You can be doing a lot of distribution, a lot of counting, pouring, licking, and sticking, putting things into unit dose carts in a hospital. You can also do a lot of patient care, counseling, talking with physicians, doing grand rounds, and so on. Just a caveat, when you have a job interview after you've gotten registered and you're asked to sign a contract for $100,000 or more, make sure it has how much time they expect you to spend in these different kinds of activities, like so much dispensing, so much patient care, so much management. This is especially true in a hospital setting. I've known a lot of people I've worked with where they signed a contract and they thought they were going to get like 80% of their time was going to be working with patients and doctors and 20% of the time dispensing functions. And it turned out to be the other way around. So be careful. Here you see the wages for pharmacists, the hourly wage, and it's been going up. I would also point out that as we get into this discussion of pharmacy staffing and such, when I was in pharmacy school in the mid-1970s, I graduated at the end of the 1970s, there was a think tank called the Pew Foundation that reported that they felt we had too many pharmacists and some schools closed. Fewer as a result of that, and even I was wondering if I should even be in pharmacy school, there were fewer pharmacists around in the 1980s and the 1990s because a lot of people decided not to go into pharmacy, and it didn't work out. We had far fewer pharmacists than what was really needed. And so in the 1980s and 1990s, it was very easy for a pharmacist to find not only one job, but maybe 2 or 3 in one particular area because there was such a shortage. We're getting back up to where those levels should be. But again, there's some thought that with all of the baby boomers retiring, those levels will go back down, and it'll be easier to find jobs. So it's kind of an up and a down, what pharmacists make and how many are around and so on. Specialization, I would just say one thing here. If you're in an urban environment or in a hospital, you probably will want to think about being more specialized in an area like diabetes, anti-asthma, anticoagulation, oncology, or something like that. Whereas if you practice in a rural environment, you probably want to have a more general approach. Now, there is something called the Board of Pharmaceutical Specialties, and they will, after you've done some training and after you've worked in that area for a year or so, you can take a test and you can get recognized as a specialist. And you see those specialties there: nuclear pharmacy, pharmacotherapy, nutrition support, psychiatric oncology, and now ambulatory care. If you're a pharmacy practice professor at most schools, you have to have that BPS specialization in number 2 there, pharmacotherapy. So you'll see this initials behind faculty alluding to the fact that they're accredited or they have a specialization in pharmacotherapy. I would say probably most pharmacists, if I was to look at sheer numbers, have a specialty in nutrition support, since it's used probably in every setting. And it's quite, honestly, I keep hearing people saying it's probably the easier of these to get. Pharmacy technicians, let's go on to these. Defined an individual working in a pharmacy setting under the supervision of a licensed pharmacist. I would also point out that a pharmacist is a professional, and they learn to deal with a lot of gray areas. Students don't like the gray areas, but in our curriculum, we try to emphasize how to deal with those gray areas. Technicians, on the other hand, learn to deal more quickly with black and white issues. It's clear cut what they have to do, and they do it. So to me, the biggest difference between a technician and a pharmacist is that a pharmacist knows how to deal with gray areas. And as such, they learn to have a professional judgment. Education and training. In a lot of states, technicians don't need to have any formal training. In fact, when I came to New York and I started listening to some pharmacists, like at local pharmacy meetings, I heard some say that they want to give teenagers they know the same opportunity they had to work in a pharmacy with no training as a pharmacy tech. I guess I can understand that, but more and more with the specialization and the more things that pharmacists have to do, they really need trained technicians. At least that's my take on it. Licensure, currently 39 states regulate pharmacy technicians. I would say in addition to state laws, there are others that mandate it, such as some pharmacy chains require their pharmacy technicians to be licensed. In the military, we require it as well. In the practice environment, the number of pharmacy technicians has increased dramatically because pharmacists are doing more clinical things. They're working with physicians. Some of the more distributed functions are being pushed off to the technicians. Pharmacy technicians work in a variety of settings: community pharmacies, hospitals, branches of the military, and mail order pharmacies. Pharmacy technicians assist pharmacists. Notice the prohibited activities. Again, this is state mandated what they can do and not do. Specific duties are able to be performed by pharmacy technicians vary by state and practice setting. So, for example, when I was licensed in New Mexico some years ago, chemotherapy could not be mixed by technicians. I don't know if that rule has changed or not, but in civilian hospitals in New Mexico, they can't, at least they couldn't mix chemotherapy. Be advised, however, that state or civilian hospitals in that state are very different from federal facilities like the Air Force Base that I worked at, Kirtland, the VA hospital. The military and the VA have their own federal rules. So although a mile away at a civilian hospital in Albuquerque, a pharmacy tech couldn't mix chemotherapy, a federal pharmacist technician could. So be aware of that. Okay, let's move on to physicians. They are primarily concerned with the diagnosis and treatment of disease. It's important to point out that they create the majority of demand for pharmacy products and services. So they write a prescription and somebody fills it. In the management course, we'll talk about this a lot more next year. But we'll also talk about ways that the pharmacist can create some demand for their products or services. We'll certainly go over that when we talk about your business plans for your pharmacy service or whatever. Education and training started in the middle to the late 18th century. Things started changing in the beginning of the 20th century. In 1910, the Flexner Report. It was a critical evaluation of medical education. They recommended minimum education standards for admission, a minimum length of medical school education of 4 years. It's a lot more now. And the closure of proprietary, that is, for-profit medical schools that existed at the time. There's for-profit medical schools now. Education and training, you can see it clearly there. Again, to become a physician, an MD in this country, you need to have graduated with a bachelor's from a 4-year program. And then you move on to 4 more years. 2 years of it, the M1 and M2, are didactic classroom. The next 2 years are M3 and M4 are more clerkships or experiential learning, something like what you're doing with your IPPs and APPs. There's a distinction between MDs and DOs. DOs, or osteopathic medical education, emphasizes a hands-on diagnosis and treatment through a system of therapy known as osteopathic manipulative medicine. They're very similar to that of students studying in MD schools. From personal experience, I see a lot of doctor of osteopathic schools in Florida. In fact, I've seen a lot of PA programs fold because they want to start graduating DOs. Licensure. The exam for licensure is taken during the second year of medical school. It's a three-step process. I should start out. There's like three different kinds of exams. There's an exam for licensure taken after the second year of medical school. That's the didactic portion. Then there's an exam when they finish their more experiential or clinical rotations. And this type of exam requires an assessment of their clinical skills with OSCEs that you'll become familiar with later in the curriculum. At the end, well, actually at the end of this semester, you'll have some OSCEs. And finally, an exam for licensure is taken during the first year of the residency, designed to assess a graduate resident's suitability for unsupervised medical practice. Now, at this point, when they finish their didactic, they finish their experientials, and they start they move from their internships to their residencies. I've been in a lot of teaching hospitals and VA hospitals where you have these residents, and believe me, these VA hospitals and teaching hospitals are full of residents, and they need your help as a pharmacist with a lot of pharmacotherapy questions. They don't get a lot of pharmacotherapy compared to what you get. Continuing medication education is required by 62 medical boards. It's called continuing medical education. I should point that out. So when you are thinking about taking a continuing education credit, either online or live, make sure that the continuing education is for pharmacists too. Oftentimes you'll see something that might interest you, but it says CME, which seems to suggest only for MDs. If it says CME, you need to check with them because it may not be suitable for a pharmacist. Usually somewhere in the information continuing education brochure for something, it will say ACPE, American Council of Pharmaceutical Education. If it does that, you're fine to go with a pharmacist CE. The number of hours needed by state and in some states varies by degrees, MD or DO, with the majority requiring between 20 and 50 hours per year. For pharmacists, again, it's usually 15, which is less. Specialization, there's MDs and there's DOs. If you wanted my opinion, MDs really know what they need to know. With DOs, the American Osteopathic Association, personally, I've seen a lot more variation in what DOs know than what MDs know. So some DOs have appeared to me very, 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 very good, and some not so good. With MDs, it's like most of them are very good. So be careful when you're talking to these two. I think there's a distinction between the two. It's pretty obvious. Maybe that'll change over time. Practice environment. I think I need to point out on this slide that there are concerns that as baby boomers begin to populate the ranks of the elderly, we may experience an even greater shortage, a hyper demand of physicians, and therefore consequently the demand for pharmacists with a specific knowledge of geriatric issues will increase dramatically. Here you see active doctors of medicine. They've gone up substantially from 1975 to about 2010. Now it seems to be leveling off. Practice environment, there's several things here. We see increases in nursing practitioners and physician assistants, although there's still, it's not a great increase. The increase in the number of physicians in primary care is the result of foreign medical graduates coming on shore, but it's not that much. Quite frankly, pharmacists, there's a lot of issues with people like on Medicaid, and governments like the state of California have come under a lot of scrutiny because they can't afford to take care of all the very poor, vulnerable populations in their state. And the reimbursement has gone down. The state of California, for example, cannot pay all of these physicians to do all the things they need. So the reimbursement rates have gone down. So consequently, the physicians got together with the pharmacists and said, well, we're going to let you in the state of California do more things than you can in other states. And this is reflected on something called the CMS 1500 reimbursement form. So in the state of California, a pharmacist can fill out a CMS 1500 form and get paid for things like counseling. So they can get paid using that CMS 1500 form low-intensity services like counseling that usually pay something like $60 an hour. Physicians, it's important to understand this, physicians don't like to do those low-intensity. They don't want to be paid $60 an hour. They would rather be paid and spend their time working to get reimbursed for medium and high-intensity services that pay as much as $600 an hour. If I could get paid doing things for $600 an hour as opposed to $60, that is good as a physician to think in those terms. But the state law also says that MDs must make sure that their patients get these low-intensity services like counseling, monitoring blood levels, and so on. So they're more than happy to have a collaborative practice agreement with a physician, with a pharmacist, to do these low-intensity services for their patients and do them right. So you see doctors of medicine in general, it's going down. But let's move on to nurses. Defined as the protection, promotion, and optimization of health and abilities, the prevention of illness and injury, or the alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations. That's what a nurse would say that they do. There's two kinds of nurses, an RN and an LPN. Simply, it's not unlike what a pharmacist does and a pharmacy technician does. An LPN is someone who has like a year's training or something like that. They're like a pharmacist technician working for an RN, or very similar setup with supervision. There's something called an APN, an advanced practice nurse. Those are becoming more common. You're starting to see nurse practitioners coming out of programs like the one here at UVille. I've taught some advanced practice nurses when I teach epidemiology, and they're sitting in the classroom. And they're actually very good. Education and training. LPNs usually 1 year, like similar to a pharmacy technician at a community college. For registered nurses, it's usually a 4-year nursing program. but it may come with either with a bachelor's degree or associate degree or a diploma from like a trade school. And we've talked about the APNs. Licensure. Prior to entering practice, there's either an exam for an RN or a LPN here. There are different designations for what they have to take. One thing I would mention here, the nurses are starting something new. Licensure is run by the states. It's not federal. And a lot of healthcare professionals have gotten concerned with the cost of licensure. So, for example, I'm licensed in 6 states. Now, that gets expensive. So some states have these multi-state licensures going on. So like, for example, I knew a lot of nurses in Virginia who get a multi-state license, and they're licensed not only in Virginia, but in North Carolina and Tennessee as well. So it's like covers 3 states at once. I think probably in the near future, you're going to see that for pharmacists as well and other healthcare professionals. Let's move on to specialization. There are certification programs available for RNs in over 50 different areas. This is akin to the BPS specialization we have in pharmacy. There's a practice environment where RNs and LPNs do a lot of different things all over the country. Again, we talked about the APNs. The APNs, typically, they've got like a 4-year degree. They're an RN, but they need more training, so they come back to the Uville and they take a year or 2 more of training. They take different courses like epidemiology and such. These nurse practitioners have a lot of latitude in working with physicians, maybe sometimes by themselves, to take care of patients. And they get paid pretty well. They're getting paid almost as much as a pharmacist now, whereas a regular RN might get paid like half of what a pharmacist does. Let's move on to physician assistants. The physician assistants in general began shortly after the Vietnam War. I mean, I had some thoughts about becoming a PA because I was a Navy corpsman, but I decided to go the pharmacist route. I thought there would be more being able to control what you did as opposed to a PA. It just seemed like you had to be near a physician all the time, and they were calling the shots. But I decided to go the pharmacist route instead of the PA route. The schooling for PAs is a lot less, and actually the pay is a lot less. I think they get paid like $80,000. It's interesting that in addition to being paid less, they have to pay a lot more in malpractice insurance. There's some thought that with more clinical duties of pharmacists, they will have to pay higher malpractice insurance premiums that are more similar to physician assistants. So that still has to work through. Okay, let's skip that. Let's go on to this. Currently, there are 149 accredited physician assistant programs. PAs are required to complete continuing medication. That's 100 hours or 50 hours every 2 years. That's a lot. PAs are retested on their clinical skills on a regular basis every 6 years. And again, higher malpractice insurance and lower salary. so it's not easy. Licensure, all states and the District of Columbia have legislation governing physician assistants. If you look at the environment in which PAs work, there are about 75,000 in the U.S. When I lived in California, I saw a lot of physician assistants in some of your better healthcare organizations like Kaiser Permanente. They do a lot of really good work and very low salaries, at least compared to pharmacists. Other qualified healthcare professionals you see here, optometrists help people correct their vision, social workers to help patients in vulnerable populations, podiatrists with people's feet, dentists with their teeth, psychologists with their mental health, dietitian and nutritionists, especially with diabetics, and occupational therapists to perform tasks like in their living and working environments. In addition, there are recreational therapists and physical therapists with help with recreational skills and functional limitations, respectively. Collaboration with healthcare providers. There's the pharmacy role. The primary role of the pharmacist is largely focused around medical consumption or medication taking. So we're getting back a little to pharmacy, not the other healthcare professions. For high-risk disease states, pharmacists can play an ever more important role as a part of the medication management team. They focus more on things like asthma, diabetes, HIV, AIDS, and cancer. There's multidisciplinary care, many different professionals, independent of each other, working for the good of the patient. In this type of model, think of it as like a tag team of people who are running a race, and one person runs for a mile and passes the baton on to another runner who runs another mile, and so on. So it's almost like a tag team type of care. Whereas interdisciplinary, many different work professionals work together for the good of the patient. So instead of like a tag team, you might have all those runners around a table talking with the patient. By the way, this is going to be a question on IRAT number 2. So you really need to know what interdisciplinary care is, where many different professionals working together for the patient's good and effectively communicating among themselves and with the patient. So, for example, I worked at a hospice down in Virginia, and we would sit around a table, all the different professionals, dietitian, the MD, the nurses, the physical therapists. We even had a chaplain there. But we would all talk about a particular patient's care, and the patient oftentimes would be at the head of the table. Very different from a tag team type of multidisciplinary care. There's a model of pharmacist collaboration and working environment relationships. I knew Randy McDonough in Iowa when he came up with this model back in the 1990s. It describes how pharmacists are gradually moving away from a traditional role where they work by themselves, like in a pharmacy or down in the basement where the hospital pharmacy is, to one where the physician is committed to working collaboratively with a pharmacist nearby. So there's different stages. You need to know these. This particular slide, will be an IRAC question. You need to know, for example, that stage 0 is where a lot of pharmacists still are. Professional awareness would be best described as the traditional pharmacist-physician working relationship, where the pharmacist is working in a pharmacy somewhere, either in the hospital or the community pharmacy, and they're working in a room by themselves, and they may just call the physician. They work up gradually to higher stages, to 5. So number 1, professional recognition involves exclusively the pharmacist is showing effort to establish a relationship with the physician. Stage 2, there's some level of commitment on the part of the physician, not the pharmacist, above and beyond to work with the pharmacist. Stage 3, professional relationship expansion, where the pharmacist can expect the physician initiates the exchange, and the content of the pharmacist-initiated communication continues to center on the benefits derived from the pharmacist working with the physician. Stage 4, which is the highest, is where there's a commitment by the physician, and he or she is convinced that the benefits of the collaborative relationship outweigh any risks. Now, in some states like California, there are, I would say probably the majority of pharmacists are at stage 4, whereas in New York, where we have severely restricted collaborative practice agreements. By and large, collaborative practice agreements, the ability to work with physician in this way is limited to just certain pharmacists working in teaching hospitals, in 6 teaching hospitals in the state. So we're severely restricted here in this state. I'm not sure why. It's bizarre in my mind, but until this changes, the legislation in this state, most pharmacists will remain at stage 0. Continuity of care is one of the last concepts we're going to talk about. We're certainly not there. We're about 2/3 through this podcast. It's important in healthcare, the provision of healthcare. Now it is uncommon for patients to see, it is not uncommon for patients to see several healthcare practitioners. Patients may have several doctors, each specializing in one organ system. To complicate matters, as people age, they are likely to move from one place of care to another. So, for example, when I was working in geriatric care at Johns Hopkins during my residency, I was working up a patient in their care plan, and the nurse showed me where the chart was for the patient, and I started reading through it. Really a thick, it must have been 6 inches tall chart to read through, with all the doctor's notes, progress notes, lab work and such. And I thought, well, I understand what's here, but it looked like, maybe were some stuff missing, and one of the charge nurses pointed into the corner of the room and said, well, there's 2 more additional parts that were about the same length, and really, it gets extremely difficult to follow these patients over a number of years, and having been in nursing homes and different kinds of places of care. The days are long gone when a doctor I'm sorry. The days are long gone when one doctor, with the help of a nurse, provided all the health care. Two core concepts or aspirations of continuity are revealed by examining continuity of care. The first being the care of a single patient. You're looking at the patient themselves, and the second is care provided over time. Now, there's basically three types of continuity. The first is informational. That is the use of information on past events and personal circumstances to make current care appropriate for each individual. The next kind of continuity is management continuity. And basically, this revolves around the patient's care plan. Now, when you're talking about a patient care plan, it's like all the things that are all the needs are met of the patient. And you're going to be going over and over this patient care plan and this management continuity in extreme detail when you start your pharmacotherapeutic modules next year. So get ready for your patient care plans. Then there's relational continuity, which is the last of the three main ones. This is where you take into consideration the ongoing therapeutic relationship between a patient and one or more providers. This is going to be an IRAT number 2 question. So you need to understand what relational continuity is, that being a higher levels of continuity of care that have been associated with higher levels of satisfaction. It's thought to foster improved communication, trust, and sustained sense of responsibility. It's a personal relationship characterized by trust and loyalty. Okay, moving on to a medical home. My finger's working here. Medical home is defined as a partnership. A medical home is a patient-centered primary health care implemented to improve the patient's health across a continuum of referrals and services. So, for example, if you have a geriatric patient seeing a number of different healthcare practitioners, a medical home is where most of the information is kept. The primary focus is to have one central clearinghouse in which all patient medication records are kept up to date, embracing the idea for shared information among healthcare professionals and thus facilitating continuity of care. There's one thing left out here. A medical home, often these records are kept online in a cloud somewhere, and I think it's part of Obamacare that patients actually have access to these records. And that's a big change from the last couple of years. Pharmacy role. While most conceptualization in the medical home recognize the physician only as the primary healthcare provider, it is evident that this initiative requires a multidisciplinary or interdisciplinary approach from the entire healthcare team, including nurses, pharmacists, physicians, therapists, and other healthcare professionals. Pharmacists certainly have a role in medication therapy management and bring something to the table. Quality. Now, we all have different conceptions of quality, but here I actually like the definition provided by AHRQ, the Agency of Health Research and Quality, defining quality as doing the right thing for the right patient at the right time in the right way to achieve the best possible results. Here you see different ways of assessing quality. I can go through these and read them all off, but I think you know most of them. Like, you know what safe, timely, patient-centered, and equitable it means. I think most students that I've taught in the past have difficulty distinguishing between effective and efficient. I think, for example, I would point out that effective means really it does it. The question is, does it do the job well? Does it do what it says it's going to do, the care? Whereas efficient is doing the job more inexpensively. So, for example, to get from point A to point B, you could buy or rent a very inexpensive car. I don't know, some Kia or a Hyundai or something like that. And that would be efficient. Whereas being inefficient, well, you could rent a Lamborghini. That would be very expensive for the same kind of job. I think you get the point. How is quality assessed? There's 3 different main ways. Clinical performance measures, assessments by patients of how well providers meet healthcare needs, and outcome measures, which we'll go over later through this course, all kinds of outcome measures like mortality rates, death rates. There's other less important or less conspicuous ways: accreditation, report cards, patient ratings. I'm not saying that they aren't important. It's like patients don't typically think about things like accreditation, report cards, and patient ratings. More specifically, accreditation. When you think of accreditation of healthcare organizations, you should think about the Joint Commission. Now, depending on who you talk to, some people might say the Joint Commission on the accreditation of hospitals. And some younger people would say Joint Commission on the accreditation of healthcare organizations. And people taking this course, new course, with the most up-to-date information, it's just called Joint Commission now. So there's been a change in names. They accreditate healthcare organizations that meet national standards, including clinical performance. If you lose accreditation, that may mean that federal funding of your organization, like a hospital, Medicare, Medicaid patients are told to go elsewhere. So it could have a dramatic effect, accreditation or non-accreditation. There's report cards. Most importantly, NCQA there, the bottom bullet, the National Committee for Quality Assurance. They produce report cards, physicians, and healthcare plans. So you can go on and look at these report cards for like hospitals in the area, like Buffalo General and Roswell, Miller Fillmore Suburban Hospital. There's a report card. These report cards are pretty important. If you have really good grades, so to speak, you can talk with the healthcare insurance providers and get paid pretty well. You can demand that you be paid more. However, if your report card is bad, you have trouble attracting those people. So you want to keep your report cards up. Like I worked at an Air Force hospital for some years down in Florida, and it was clear that we had report cards from patient satisfaction cards that were submitted to us from patients, and they said that their ratings were going down, like they felt like they weren't being treated properly by people at receptionists and such. So the Air Force commanding officer of the hospital had Disney, Walt Disney, the people come in and provide a customer relations seminar that taught us, like, well, if a patient looks like they don't know where they're going, you're supposed to ask them if they need help to find, like, the lab or the radiology department, and you would stop everything and escort them there. And our ratings went back up. So this is something that healthcare organizations are all constantly working with. Patient ratings, well, we kind of went over that pretty well with the Disney. Important trends affecting healthcare professionals, patient-focused care, really. This is important, so I'm going to read word for word the next two slides. Patient-focused care characterized by decentralization of services, cross-training of personnel from different departments to provide basic care, interdisciplinary collaboration, various degrees of organizational restructuring, simplification and redesign of work to eliminate steps and save time, and an increased involvement of patients in their own care. It also, on the next slide, patient-focused care attempts to improve patient care by organizationally and physically moving selected service functions such as basic lab, pharmacy, admitting, med records, housekeeping, and material support to patient areas, thus affecting an organizational restructuring. So, for example, cancer, there's a chain of hospitals that cater to cancer patients, and rather than the patient walking around to talk to different professionals in the hospital, the professionals actually come to one room and talk to that patient and their family. So it's kind of like when you took your student interviews here at D'Youville at our school of pharmacy. When you come for your interviews, you basically sit in one room and like 5 or 6 faculty come to you. Team steps, really important. The Department of Defense and the Agency for Healthcare Research Quality put together Team Steps, which is a comprehensive set of ready-to-use materials and training curriculum to integrate teamwork principles into any healthcare system. I would note that this is part of your interprofessional education that you're going to get in the 3rd year. So when you see these team steps as part of your materials in the 3rd year when you're taking your IPE, you'll know what I'm talking about. I'm going to skip this slide. Critical pathways, critical to know what this is. The 3rd slide especially, a critical pathway is an optimal sequencing and timing of interventions by healthcare professionals for a particular diagnosis or procedure designed to minimize delays in resource utilization and maximize the quality of care. So, for example, we talked about patient care plans earlier in this podcast. Part of putting together a patient care plan might be looking at these critical care pathways. So you might, look up a critical care pathway for somebody suffering a particular form of cancer, and you'll see this sequencing of things that have to happen. So, for example, with some forms of cancer, you have to give something called 5-fluorouracil, very common chemotherapy medication, IV. But before you do that, you have to give the patient a lot of fluids, like normal saline, and you have to give them diuretics like furosemide. And you have to do that in a certain sequence. Again, this is going to be something you're going to see during your pharmacotherapeutic modules starting next year. CQI, this is an incredibly important concept, and it's one you're going to need to know during your career. It's also on your IRAT number 2 questions. In particular, you need to know that CQI functions as a methodology for examining and improving the process of care and patient care outcomes, regardless of internal, departmental, or profession-based organizational boundaries. So know what CQI is. Now, when we get into CQI later in this course and later during the management course next year, you need to know two acronyms used to explain the CQI process. Basically, the focus is something that takes place in a linear fashion, almost a line, whereas a PDCA part of it, it's almost like a cycle. You keep doing it over and over. So you can read those. The PDCA is the part I want you to get right now. After a process is set up, you plan the improvement, you do the improvement, you check and study the results, and you act to hold and gain and improve the process further. Next, there's something called pay for performance, is defined as quality-based purchasing. You need to know this too for the IRAT number 2. You need to know that the P4P concept is centered upon the idea that if patients take better care of themselves, they will be paid on how they maintain their chronic disease. That is not what I'm trying to say. Is that's what people think the P4 concept is, but it's not. That's false. P4P is an incentive plan for providers to contain costs. It's also for payers to contain costs. So that's what P4P. It has nothing to do with the patient trying to make things better. Moving on finally to technological advances, you need to know how things are changing technologically. You as a future pharmacist need to get friendly with the advances in technology. There's handheld devices where you enter data, like for example, into a tablet while talking to a patient. There's e-prescribing, where a physician enters prescriptions information into a system for a pharmacist to check and fill on another computer, maybe miles away. And finally, there's the electronic health record or the electronic medical record, where all the information for a patient over several years is contained in the cloud or on some portable device. And that's the end of this